Okay, good morning, everybody. So it's good to be here. I'm not sure that I'm fully awake yet. So I did drive in this morning from St. Louis, and unfortunately, I won't be able to be here the whole day. I have to head back to the nursing home this afternoon or later this morning. But immediately following this, if you have additional questions, I can stick around for a little bit. We can kind of talk out in the hall, or feel free to email me as well at any point. I'm not sure if that information was in there, but it's mlittle6@slu.edu, and I'm happy to answer questions that way as well. So this morning I'm going to be talking about dementia and some of the updates, or maybe not even so much updates, but how we might think about approaching dementia in our patients and residents, if those of you might practice in long-term care. That kind of gets us away from thinking that all dementias are Alzheimer's. And so we know now there are a lot of different types of dementia, and how do we best assess, evaluate, and manage those patients. So why do we care? Mostly I'm preaching to the choir here, but dementia affects everybody, old and young. These statistics are the most recent, that recently released this year from the Alzheimer's Association. So significant morbidity, mortality, and cost burden to our patients in our society. Everybody has a personal story as well. Mine began with my grandmother. So I'm from Southwest Missouri. I was born and raised in Springfield, Missouri, so I'm a native Missourian. However, my parents are both immigrants to the United States, and my grandmother came over when she was middle-aged. And so she had valvular heart disease when she was a young girl in Central America, and she ultimately developed atrial fibrillation, other valvular complications, and had multiple strokes and developed vascular dementia. So as I was growing, I witnessed personality changes, agitation, and the most amazing caregiver through my mother, through all of that, who still, at every year of the anniversary of her death, mourns. And that was, I don't know, probably close to 20 years ago now. So we all have personal stories like that, and that's why we in the room care, to make a difference so that we can make a difference in the lives of our patients and our caregivers. The most important thing to remember is that dementia is not a normal part of aging. There are certain aspects of cognitive decline that we can expect, certain things that we might call senior moments. But when it comes to actual memory loss, that is an impairment of function, that is not a normal part of aging, and we need to really make sure that our patients and our family members are aware of that. So the other important thing to remember too is that dementia is a blanket term. So it's not good enough just to say that someone has dementia. We have to quantify that better for our patients so that we know how to adequately manage them. So a lot of my slides may look like they're repeated information. If you see repeated information, it's because I think it's important enough to tell it to you 2 or 3 times. So these are some of my take-home points. I also like to give those up front so that you know what I think is most important. So dementia, more specifically, if we're going to define it, it is a memory impairment that's not just memory loss. You have to have some other cognitive impairment, so aphasia, so maybe the person has difficulty with language, either comprehension or expression of speech. Apraxia, so this is where a person has difficulty with motor coordination, previously learned tasks. So this is not difficulty learning something new, this was where something had already been learned in motor function that is now being lost or has lost. Agnosia. So this is the inability to recognize something, whether it's a smell, an object, faces, sounds. So I think when I was in medical school, classically we learned the man who mistook his wife for a hat, where you may have heard that story. He saw the hat rack and he couldn't tell the difference between the hat and his wife's face because he was losing that ability. And then executive function. So this is the control of behaviors in general, such as attention, inhibition, memory, cognitive flexibility, some of those other higher level tasks. Also important is that it's a decline from a higher level of functioning. So important to note too is I'm going to show you a quick test that we think is good for everybody to know how to detect mild cognitive impairment and dementia. But some of those screening tests don't pick up people who have a lot of education. So those people, a lot of that is a clinical diagnosis where we get the history, we take a really good history, and we find out they have had a decline from previous level of function. Even if we don't pick it up on our screening tests, those are the ones we would need to refer for more comprehensive neuropsychological testing. So several years ago, the International Association of Gerontology and Geriatrics got their brains together and they said, what is most important for us to understand about diagnosing and management of dementia? And these were the 4 things. So we need to know if people have cognitive impairment because we need to know if people are able to follow our instructions. And I'll talk about one later, but classically these are people with diabetes who have hyperglycemia or hypoglycemic episodes who are not able to think and therefore are not able to follow our instructions of complicated insulin regimen very well. So we need to know. The other thing is we need to know if they have a treatable cause of cognitive impairment. And if we find it early enough, we might be able to reverse that. We need to know that there are lifestyle interventions that can delay the rate of cognitive impairment that we can implement that'll be most effective done early and as primary prevention as well. And then early diagnosis not only allows us to find reversible causes and put into place lifestyle interventions, it also helps us to do advanced care planning, which should start at the onset of the diagnosis. So why do we want to diagnose early? I've already mentioned several of these. Again, key take-home points. Look for those reversible causes of dementia. Sometimes, in certain disease states, we may not reverse it, but we may be able to stall the disease. We're going to be most successful in this if we find it early. We can help the loved one and the person himself to participate in care planning and advanced directives for the end of life. It's never too soon to talk about when you're going to retire from driving, when you're going to retire from your work, what you're going to do when you're no longer able to take care of yourself. Those are conversations we need to have while the person is still able to participate in that decision making. And making sure that there is a primary decision maker. Too often, and we're dealing with this with 2 residents right now in our long-term care setting, where they did not identify a decision maker and they are not able to tell us their desires and the family is not in agreement. So we are stuck. And especially important in the state of Missouri where we don't have an automatic chain where we know we can go next of kin, this person, that person. So really important for us to have these conversations early. So in diagnosing dementia, use a validated tool. There are a lot out there. Certain ones are free, certain ones are not. You should know which ones are not so that you don't get stuck with the bill one day if someone finds out you've been using it. Any tool from St. Louis University is free to use. You don't have to have permission. I know Dr. Morley is going to talk about the rapid geriatric assessment. If you do use that, we would love to know just so that we can count those numbers to see what people in Missouri, how everybody is in different areas. But you don't need our permission to use it, and you can copy and distribute as will. So we have 2, the St. Louis University Mental Status Examination, and then the short version that I will show you in a moment. Again, very important to not just identify the presence of dementia, but to identify the underlying cause so that we can institute the proper treatment. So here's the rapid cognitive assessment. How many of you are familiar with the St. Louis University Mental Status Exam or SLUMS? Okay, a good many of you. How many of you are familiar with the short version? So several, not quite as many. So basically what we did was took the 5-item recall, the clock drawing test to be the distractor, then you ask the questions again, and then the story, but you only have them answer 1 question of that. So it takes the test from being 8 to 10 minutes long to about 2 minutes in length. So it's much easier. So I am going to show you a video just to kind of get our minds jump started, take a little break from me yapping at you so that you can see it demonstrated.
Lastly, I'm going to ask you some questions about your memory. Some are easy, some are hard. Do your best. Please remember these 5 objects. I will ask you what they are later. I will read them to you and you repeat them back to me. Apple, pen, tie, house, car.
Apple, pen, tie,
Okay.
I'm sorry, I can't remember the other 2.
I'll repeat them again. Apple, pen, tie, house, car.
Apple, pen, tie, house, car.
Good. This is a clock. Put in the hour markers and the time at 10 minutes to 11 o'clock.
You want just markers?
The numbers, the hour
right.
markers, yes.
And you want 10 minutes to 11?
Mm-hmm. Okay. Take the pen.
Sure.
What were those 5 objects I asked you to remember?
Apple, pen, tie, I don't think I can remember the other 2.
Okay. I'm going to tell you a story. Please listen carefully because afterwards I'm going to ask you about it. Jill was a very successful stockbroker. She made a lot of money on the stock market. She then met Jack, a devastatingly handsome man. She married him and had 3 children. They lived in Chicago. She then stopped work and stayed home to bring up her children. When they were teenagers, she went back to work. She and Jack lived happily ever after. What state did she live in?
Well, they lived in Chicago, so that means they would live in the state of Illinois.
Good. Rose scored 6 out of 10 on the rapid cognitive screen. The higher the score, the better the cognitive function. 8 to 10 is normal, 6 to 7 indicates mild cognitive impairment, and 0 to 5 indicates major neurocognitive disorder or dementia. Finally,
So all of those videos, our training videos, are on the website aging.slu.edu. Please feel free to go there and access those at any point. And we have a few others in addition to that one. So the rapid cognitive assessment. So how does this compare to some of the other short versions? So the mini-cog may be one that you're more familiar with. It's very similar. It has a clock drawing test. It only has 3-item recall. And so it's pretty good at picking up dementia, but when it comes to picking up the earlier, milder prodromal form, it's not as good, whereas the rapid cognitive assessment is better than that. So that's the one on the left. The area under the curve, you want to have a bigger space there because that means that it's better at picking it up. It's good for both MCI and dementia. So as I said before, it's not enough just to diagnose dementia. We need to figure out what are our causes. Why do we want to do that? Reversible causes, which I will talk about in just a moment. Distinguish the syndromes, and provide that complete biopsychosocial care. These are the reversible causes, the major reversible causes of dementia. I stole this slide from Dr. Morley, and when he gives this, if those of you have seen him give this lecture, it's much more entertaining because he uses the presidents as examples. I'm not quite as bold and as cheeky as he is in terms of being able to do some of what he says with them. So here you have it. Again, we have this information available to you. It's in the form of a mnemonic, so if you can remember dementia, you can remember the mnemonic dementia. So drugs being a major thing, always, always, always reviewing the medication list, looking for certain types of infections, depression, B12, hypothyroidism. Nice study showed that people who had earwax, a significant earwax buildup, removing the earwax actually improved their cognitive scores by a few points. So looking in their ears, making sure we give them corrective lenses. Looking for any kind of brain changes that are reversible. So a space-occupying lesion, a meningioma in the case of someone I'm caring for now, and normal pressure hydrocephalus that can be reversed if caught early enough. Atrial fibrillation, again, caught early enough, alcoholism, and sleep apnea. Sleep apnea is probably one of the most underdiagnosed causes of MCI. So if you find someone with MCI, whether or not they snore, they should be referred for a sleep study. So we also want to make sure that we've ruled out delirium because there are some dementia syndromes that look a lot like delirium. If you have pure Alzheimer's, they look very different. But some of the other ones there can be a lot of overlap. So the big thing about delirium is that it's acute and fluctuating, and it usually fluctuates over minutes to hours. So the dementia syndromes, if they fluctuate, it's usually more consistent at the same time of day. The sundowning doesn't necessarily have to be in the evening, but it's usually consistent at the same time of day, usually fluctuates days to weeks, not quite as rapidly as delirium. So in both situations, you want to look for those reversible causes first anyway, and that would be your first step in management. So let's talk about the dementia syndromes and how to kind of distinguish some of the ones that are not necessarily Alzheimer's. So these are the major ones that we're going to talk about this morning. There are a bunch of others. So I think I heard at one time there may have been around 100 different types of potential dementias. So a lot of them are very, very rare. Some are much more common, and these are going to be the more common ones you might encounter. So that first graph that you see down there at the bottom are the hippocampal sclerosis of aging. So what this is when you have significant neuronal loss, so loss of neurons, and gliosis in the hippocampal area, which is also one of the areas affected by Alzheimer's disease. But you have greater loss of neurons in this condition than you do with Alzheimer's disease. So it's out of proportion for what you would expect, and you don't have the same level of amyloid plaques in the rest of the brain. So this is the key Alzheimer's mimic. The reason it's important to try to figure out if someone has this is because they don't respond to medications that were designed for Alzheimer's disease. So these are the people, they look just like Alzheimer's. You put them on the medicines and they decline just as rapidly or get worse quickly. So this is going to be a huge population of patients, and unfortunately we don't have good medication treatment for this. These people also tend to live longer. So these are the ones that may have had a diagnosis of Alzheimer's disease 20 years ago and they're still living with the disease. So they probably have this instead. A lot of supportive care. Primary age-related tauopathy. So this is where you have the neurofibrillary tangles. So in classic Alzheimer's dementia, you have both the amyloid plaques and neurofibrillary tangles. So you hear plaques and tangles, plaques and tangles. In this particular disorder, you only have the tangles. You don't have significant plaque formation. So again, it's going to respond differently to the medications that we typically would use for Alzheimer's disease. So Also, you tend to see disease that is in the medial temporal lobe and the brainstem structures, so it's going to be more there. So as we move forward with understanding these conditions more, we will be using more and more brain imaging to make these diagnoses. It's not mainstream yet, but now understanding these conditions now will help as they develop the imaging techniques to use down in the future. So this is very common in people over 80. These people tend not to have as severe a disease. So they tend to have mild memory impairment, mild cognitive impairment, and they don't quite get to the severity. So these are often the people that kind of die with their disease and die of something else, as opposed to dying of the dementia itself. Vascular dementia, huge part. Probably the majority of the people we see have some kind of mixed pathology. There's so many vascular risk factors in our population that we have a lot of people with vascular dementia. And they may have other pathologies on top of that. So the really nice thing is this Hachinsky score. So if you're thinking, I'm not sure, could my patient have a component of vascular disease where we need to modify the vascular risk factors more aggressively? You run this score here. So the Hachinsky score helps you to determine if it's high, so if it's greater than 7, very high likelihood that the person has either pure vascular dementia or at least a component of that we should be aware and treat those and modify those risk factors. Lewy body dementia. Getting more and more press as we find that it's more and more common. This is the one that probably looks most like delirium. This is the one that I find very challenging, not only to manage, but to diagnose. Because early in the disease looks a lot like all of the other dementia syndromes. It's not until later, when they start to develop more severe Parkinsonisms, when the hallucinations really start to kick in. A key thing is these are usually visual. A lot of times they're not disturbing to the patients necessarily. They're usually disturbing to everybody else because the people start to saying, I'm seeing people in the yard, or somebody came over yesterday and was sitting with me on the couch. And it can be disturbing to the people caring for them, even if the people themselves aren't disturbed by the actual hallucination. And that's important to keep in mind, make that distinction, because we don't want to treat a psychotic episode if it's not disturbing, because these people can have worsened agitation, worsening Parkinsonism if we use antipsychotics. So we have to be very careful with how we manage them. So this population is very, very tricky. There is some evidence that they might respond to the medications that were designed for Alzheimer's disease in terms of agitation. Usually does not necessarily affect disease progression, and the evidence we have is actually pretty scant. So that you have to really weigh the risks, benefits when you're talking about treatment in terms of delaying the progression of disease. These people need a lot of support. Their families and caregivers need a lot of support. This is a very, very challenging diagnosis. And it looks so much like Parkinson's disease itself that people get confused. So what I make sure to stress is if the Parkinson's came first, so the tremor, the abnormal gait, the falls, the autonomic dysfunction, that came first, and then the memory loss, that was probably Parkinson's. And we just failed to identify it early enough. If, on the other hand, they said, you know what, I've actually noticed that mom's been having some trouble with memory for like about the last 2 to 5 years, and it really got worse lately, and now she has this tremor, and she has this shuffling gait. It looks a lot like Parkinson's I've seen online. That's probably Lewy body disease or a related condition. There are probably about 4 or 5 what I call Parkinson's plus conditions that are very similar. Lewy body is the most common type. Did I miss? Again, neuroimaging is the best way to actually identify this, but not mainstream. I mentioned this already. Diabetes is associated with cognitive impairment, particularly if you have people with long-standing hyperglycemia, or if they're having multiple hypoglycemic episodes. So it's important to know if somebody is having this, and sometimes it's hard to pick that up just based on A1C. But if people are hyperglycemic, they can't think regardless of what pathology you actually pick up on the brain. So if we did brain biopsies, you may not pick up significant pathology, but they would still have difficulty thinking. They also tend to have more of a vascular pathology, which makes sense. So diabetes is a major vascular risk factor. We treat it as an annual equivalent in many cases. So in these people, they tend to have more of a vascular type of pathology versus those tangles and plaques that I talked about earlier. So these are the ones you want to get more aggressive with modification of vascular risk factors, lots of lifestyle modification. These people, you need to make sure that there are many ways that we are conveying how to control their diabetes. Just verbal face-to-face in the clinic, they're going to come back and then they'll be labeled as non-compliant, when really it's just that they just weren't going to process what they were told. So now we get to Alzheimer's disease. Dr. Morley will tell you that the preferred term is hyperamyloidosis because there are many people who actually played a role in what we understand of Alzheimer's pathology. So the amyloid theory is not a new theory. So this has been around for a long, long time. It was discovered in patients with Down syndrome. So we know people with Down syndrome develop Alzheimer's pathology early. And so people who studied Down syndrome patients discovered hyperamyloidosis about around the same time that some of the other labs were also looking at this. So those of you might know, or you might be familiar with some of the research that has come out in terms of amyloid and thinking about immunization. So can we give a vaccination against amyloid and cure dementia? Unfortunately, none of those trials went very far because people ended up getting worse with those types of vaccinations. So it begs the question, well, what is the actual physiologic role of beta amyloid? Why do we have it in the body in order if it's just going to make us develop dementia down the line? So some of those have been answered by several different labs. So the first thing is that a lot of older adults who do not have the clinical evidence of dementia, so they don't have memory loss, they don't have impairment of function, they don't have any other cognitive impairment, they still have amyloid plaques. So they have amyloid too in high doses that has developed over time. So now what is the difference? We also know that low doses of beta amyloid given to young animals, so these next couple slides are animal studies, enhances memory. So seems like we need some beta amyloid for memory, and that in certain people, having too much didn't cause problems. So the hippocampus, again, that's the area of the brain that we think is most associated with Alzheimer's disease. Low doses of beta amyloid actually augmented that area, augmented our ability to use that for cognition. And if we inhibited beta amyloid in young animals, they actually develop dementia and memory loss. So the physiologic role of beta amyloid is memory enhancement. So we can't wipe it out. So what is currently being studied is how do we then reach that happy medium? That seems to be the thing now in healthcare. We used to think, well, if the lower you go with blood sugars and lipids and blood pressure, the better. But we're actually finding no. It's a J-shaped thing. We need these things. Of course, we can't have a blood pressure of 0. We have to have blood pressure so that we can perfuse our organs. We need to have beta amyloid so that our brain can think. So how do we then come to some happy medium? And I wish I could say we have this great new medication. You're all going to be using it tomorrow or Monday, and everybody's going to be cured. That's still in the works, but it's important to understand some of the background behind this and why a lot of the things to date haven't necessarily worked. The other thing that plays a role that's not just beta amyloid, too much beta amyloid, is the cytokine theory. So when you have a lot of cytokines, you get inflammation or swelling, you get cells that are being broken down and killed, and then so not only do you have plaques, but then you have damage related to inflammation. So how does that relate? So this is a wonderfully complicated slide that basically kind of puts all these pieces together to say, how does this play a role physiologically as well as pathologically? I don't particularly love this slide, so I'm not going to talk through it. It's easier to see in this slide. So do I have a pointer on this? I do. Oh, and it works. So we're talking here now for hyperamyloidosis or Alzheimer's type pathology. So you have some people who have genetic predisposition. That's not that many. So there are a few people we can pick up their genetics, and we say you're going to be at very high risk, we're going to do something. So you have some genetics. For most people, you're going to have some kind of chronic inflammation, whether it's vascular infection, trauma. We've probably all taken care of those people who had that big fall, hit the head, and then 2 years later they're coming to see us, and families say, you know, ever since mom hit her head, she hasn't been the same. So some kind of damage to the brain. And then that is added here. So we've made our beta amyloid. So this is the amyloid precursor protein, makes our beta amyloid that increases acetylcholine and increases memory. So this is normal. You get these insults that come in here. You develop the pathologic tissue. You develop plaques. You have some people that don't have memory impairment, but then you have the people that you continue to have pathology. That's when you get those tangles. When you start to see those tangles develop, you continue to have brain damage. You continue to have these vascular insults. Then you get this memory impairment. So it is not simple. It's so many things going on. And that's why we don't have one drug or even two drugs that we've seen have been the great poly pill or super pill to treat even pure Alzheimer's disease, because it's not pure. So a couple of other types of dementia. So Pick's disease. So this is classically frontotemporal dementia. And or classically Pick's disease is now called more frontotemporal dementia. These are the people that will have a primary changes of behavior or problems with language. So this is the classic Phineas Gage syndrome. So Phineas Gage was a worker on the railroads who had an accident, and a rail spike, flew through his head and entered and exited the skull. And he kind of laughed it off and went on and continued work and got checked out and appeared fine. And then all of a sudden, he was angry, mean, sexually inappropriate, and was no longer able to work because people could not tolerate him anymore. And so there are lots of things written up about him, and he became quite famous for that. So the frontal lobe is important for our behavior inhibition. So when you take that away, that's when people have the significant personality changes. So if it's a major personality change, you want to consider this. Again, this doesn't respond to the classic medications we have for dementia. These are also the people who have a lot of problems with language, either comprehension or expression of language. These are the people that should have aggressive speech therapy early in their treatments. All right, again, another slide. Complicated, but let's talk through it a little bit. So all the different causes of dementia, of course, these are some of the other more rare ones we didn't really talk about today that all goes into that. Don't forget your treatable causes. You have the vascular damage, all these other things that affect the brain and cause inflammation. We have our primary age-related tauopathy, hippocampal sclerosis of aging, diabetes, Lewy body, and finally Alzheimer's. So these are going to be your most common ones here, in your vasculars, your treatable causes, and then your other dementias. So if you don't already have these slides, I can make them available for you. I don't know if that's part of of this conference to make them available for you, but if you need them, I'm happy to make these available for you so you have this for your reference. So, in the last part of this, I'm going to talk about management. I'm going to pause just to allow for people to ask questions at this point, if anybody has any burning questions about what I've talked about so far. Okay. All right. So, of course, those treatable causes. And when I give a delirium talk, I feel like I'm always saying, find the underlying cause, treat the underlying cause. And so it's the same with dementia. We need to always constantly be looking for those underlying causes that we can reverse, and maybe not reverse completely the dementia, but maybe make them a little bit more functional. And then lifestyle interventions. So I've talked about a lot of conditions that don't respond to the medications we have. We have typical pure Alzheimer's disease and why and not all people respond to the medications and why eventually they stop responding. So we have to do other things. We have to get very aggressive with this, and we have to start lobbying to get these things paid for, because this is what is most effective. Diet, exercise, brain stimulation, socialization, and then all of the things that we do for safety. And then, of course, I'll talk a little bit more about the medications specifically, but for me it's always plus, big minus. So let's look at the cholinesterase inhibitors. So lots of data. I know this is kind of one of those ugly busy slides again, but this is the big take-home point over here. The studies do show statistical significant benefit. So they improve points on whatever cognitive scale, whether it was MMSE or MoCA, whatever scale was used in the studies, they do improve. But clinically, it doesn't translate to very big differences. And for most people, what we can expect is maybe delay the progression of the disease. We don't have a lot of long-term studies. Some of the longest-term studies go out about 5-6 years. Most studies are 6 months to a year. And people suffer with their dementia illnesses for 5, 10, 15, sometimes longer. So what do we do with the medicines after a year when our studies have run out? So not a lot of great evidence for use of this. Some mixed evidence for use in agitation in dementia. So for some people, the side effects are small enough that it's worth a trial to see if it makes a difference. Side effects, most importantly for this group of medications, are nausea, GI upset, and so that's something to consider in people who are at high risk of losing weight. Same thing. So, all right, memantine is the other major class that we have for treatment of dementia, specifically designed for treatment of Alzheimer's disease. Has also been studied, smaller body of evidence, but some studies in vascular dementia. So again, the initial studies show it does improve some points on memory testing. The most important study, I think, was the one that came out, how long was it? It feels like it was last year, but it was just, so it's 2014 already. Time flies. So it's a few years ago, this study came out where it looked at functional status. So how well do our patients, not only does it improve their memory, but does it help with their functional decline? So this study was actually really famous. So everybody heard about this study, the VA trial for memantine. What everybody heard about was vitamin E works to prevent decline in dementia and functional status. But if you look at the evidence, vitamin E did no better than memantine. Or no, vitamin E did better than memantine, but not really better, but neither did better than placebo. So what it tells me is memantine doesn't work. So nobody kind of said anything about that. They were very excited about their vitamin E trial, vitamin E outcomes. But it just basically showed, memantine doesn't work, at least for functional status. And that's probably what's more important for our patients coming down to it is, how long will I be able to drive? How long will I be able to dress myself and feed myself and do my finances? And I want to live alone. So that's more important, really, than how they score on a test. Oh, also, orthostatic hypotension and falls. Again, already high-risk population increases their risk further. So important to know that. Exercise. People keep doing exercise studies, even though almost every single one is positive. So how much more evidence do we need to get people to start doing this and to get this paid for consistently across the board? Because we need to get people to actually go out and do it. And a lot of people can't afford necessarily to go to the YMCA, especially where I live. So it helps to decrease brain atrophy, increase cognition, dysphoria, so it helps with those behavioral and psychological symptoms of dementia. all of them, but that one that's hardest to treat, which is the apathy, exercise does help that. This life study, sorry it's in white, but the life study actually showed that high dose exercise. So we need to do moderate intensity exercise regularly, so most days of the week. The finger study is the Finnish geriatric study. Looked at lifestyle modification, mostly diet and exercise, and a huge population. You might say that, well, those are Finnish patients. They're not really our patients here in Missouri, but still, very large, nicely done population-based study showed improved outcomes, significant cognitive outcomes with lifestyle modification. So we know diet, so Mediterranean diets. Not only is it a lot of fresh fruits and vegetables, a lot of omega-3 fatty acids in the fish, but high levels of olive oil. So if you're going to use an oil, olive oil is the best. You have to use it on everything, pretty much. I mean, you have to have pretty high levels, a lot higher than what we typically eat here. Exercise, and then some kind of cognitive stimulation does improve cognition. Now, the caveat to the brain games is you can't just do any brain game that you find on the internet. So there are some people that are getting their money back for paying for certain protocols that have not been shown to work. So you can't just get on and so, my excuse to my husband is I play so much Sudoku is because it's going to keep my brain, but that it's not actually going to. So you have to be more engaged. You have to and you have to ramp up the level. And there are certain people who are trained to do this. So a lot of speech therapists are now getting trained to do the app-based cognitive training. So you can't just give somebody an app and say go. You kind of have to have some guidance with it. That's what the literature is starting to show. Or to have some group-based cognitive stimulation, which we have a group that's going to be talking about that later today. And that's this. So this is the cognitive stimulation therapy groups where you not only get them engaged cognitively and they're doing mind puzzles in a fun way, they're also socializing. So you increase that socialization, and a lot of groups, the groups down here in Southeast Missouri and some of the ones in St. Louis have added exercise, where in the UK they just did the cognitive stimulation. But you're adding socialization, exercise, and these brain games, and you're getting it all together in a package. So you'll hear about that more later. So, my conclusions, you've heard all of this already. Early diagnosis. So that's why we developed multiple screens at St. Louis University, trying to shorten them so that it's easy. Anybody can do those screens at any point. It does not have to be a physician or advanced practitioner. Anyone can do them and identify it and then start instituting therapy. Because so many of these, they're non-medicine things that we should be doing. So anyone can do these for our patients. Identifying and treating those reversible causes, naming that dementia, really trying to help our people understand what they're living with and what they can expect in the future, helping them to plan for the future and what they will do when they're no longer able to take care of themselves. Lifestyle, cognitive stimulation, social supports, advanced care planning, and medication management. So I did talk, polypharmacy is my big thing. That's the thing I love to talk about the most. And how do we reduce medication burden on older adults and what's no longer appropriate as people age. And so it's really important, and it really does take a team effort. So I'm a prescriber, so it's easy for me to prescribe or deprescribe, but it's not necessarily easy for me to identify the medications that someone is taking. So it takes a lot of people to help with this, and also to educate people that, yeah, that medicine worked great for you 20 years ago, but now is it really helping you? So that kind of thing is a team effort, so everybody's involved in that. So this is my daughter, and she wants to know if you have any questions. I changed I have another picture that I usually use that I might have used for some people in this crowd, but she's holding a two-headed baby. So her first baby doll was one of our Halloween decorations. And she loves this thing. She tried to take it, so now she's just started taking her baby dolls to the bed, and she tried to take it to bed with her other baby dolls, and that was where I drew the line. But she has another baby doll that's almost as creepy because it's two baby dolls kind of put together. So I always say that, I take her to nursing homes with me. So if she doesn't become a geriatrician, I think she's going to be a burn unit nurse because things like that do not frighten her. And she pops the head off all the time, so I don't think she would have any trouble pulling dressings off of people who have burns. So, any questions? And I finished very early, yeah.
I have a question. Sure. It is so difficult sometimes to get people diagnosed. And here you are saying that is the main thing that we need to do. So are there like referrals to the units that you're talking about, or to you or Dr. Morley?
Yeah, so the question was, it's very hard to get people diagnosed. So how do we get that diagnosis, and how do we make those referrals? So yeah, there are a lot of centers, so in certain areas, such as Springfield, we have some of our trained geriatricians down there, St. Louis University, Washington University, UMKC, KU Med. So some of those big centers, yeah, we're going to have lots of specialists. But how feasible is it for your people to go up there and get that diagnosis? How often are they going to want to go and do that? So the referral is probably going to be those people that somebody has identified something is wrong, but we don't quite know, and they need neuropsychological testing. That's probably, I mean, I'm not familiar as much with the west side of the state, northwest, but I know in terms of St. Louis University and Washington University have those services. So those are going to be the 3 or 4 hour tests to determine what exactly is going on, what domains exactly are being affected, and probably for the ones that have really high levels of education. Those are going to be the people that you definitely want to send up there. Everybody else, what it takes is us doing this type of thing, sharing what our tool sets, helping healthcare systems to get it in place, changing the culture and the mindset so that it is commonplace for us to check this as part of rooming a patient, just like we check blood pressure. So, even in my clinic, I have a geriatrics clinic, the nurse who rooms the patient now is doing the rapid geriatric assessment. And so she does that, and then I can come in and say, oh my goodness, you've had 3 falls, or you've had, the cognitive part of the assessment, the 2 minutes, if that's part of the rooming process, now we have a protocol of how it's done. We need more people trained in how to care for older adults, and of every profession. So, not just physicians and geriatricians. We need to train nurses and social workers and therapists and dietitians, and everybody who's on that team needs to be trained to know how to do this and understand it to help make that diagnosis. So once anybody can do the screen. And then I would also advocate that, so those of you who are specialists and older adults and are learning to be that, coming to conferences like this, to develop relationships with the people who might be more resistant. So, I do get a lot of referrals from certain primary care practices where they're not looking at this at all. So, how do we help to engage them more? I actually saw 2 people yesterday whose primary care, I looked at them and I said, I'm not going to help you at all. Your primary care doctor is doing all of this already. And the guy said, I did the slums, and he said, I already had that one 3 times. And I said, well, why are you here? And so that's what we hope for. That's what we hope for, is to really disseminate this and diffuse this so that it's commonplace. Everyone's doing it, no matter your profession. We're constantly looking. And yes, utilize our resources that you have at St. Louis University and all the other centers to help with the education, to help with the more complicated patients. But for the most part, we just really need to get the word out. So, yes.
Question, a couple of them actually. What do you think of this early stuff on raw coconut oil? There's some, I'm not talking about the processed coconut oil, but the raw, unprocessed coconut oil. There seems to be some backdoor theories about that helping with amyloid, perhaps?
Yeah, so the question was some of the early evidence on raw coconut oil, so pre-processed coconut oil. So my understanding is that it has a lot of anti-inflammatory properties associated with it. And so it probably goes back to, if that does bear out to be a very good intervention to put into place, it probably goes back to this crazy slide here of some of this inflammation going on and bringing down inflammation. So that's why we think olive oil works. That's why we think red wine works. The resveratrol in the wine has anti-inflammatory properties, and so it's probably very similar. Am I on the coconut oil bandwagon? No, not necessarily, not yet. I don't discourage my patients if they say they want to try it. I actually had somebody who was losing a ton of weight, and she started using it, and it helped her to kind of gain weight because it's pretty heavy. But yeah, I think that's probably what it goes down to. It's again, I don't think we'll ever have the panacea where we say this is it, and this is you give this to your patients, we're going to cure all of this because of this slide, because this is so complicated. Yeah.
I do find it fascinating at educational level, does even impact that rapid geriatric assessment kits. I use that all the time, but I take care of the school systems in Notre Dame, and I swear those women, they can get by some of that really easily, even though when you know they have a significant deficit, especially the clock face. I mean, I have a woman that's like way out there. She's probably got a score 2 on her RGAT, but the clock looks lovely. I mean, it's like 3-dimensional, and all her hands are on the right place.
She may have been, was she a teacher? Yeah. So the comment was the educational level really impacts those screening tests, and particularly in the clock drawing, where beautiful clock, but clear cognitive impairment. So, and they start memorizing the tests too. So interestingly, the couple I saw yesterday, so I saw them together, and I did his slums first because he was the one that came in with that complaint. And his wife was like, no, I don't have any problems. So I did it on her, but I changed up the questions and I changed up the words, and she actually fumbled and wasn't able to do it. So it's interesting that they do start memorizing it, even if they have cognitive impairment. So the other thing that's related is, what are we going to do? There are people who don't know what a clock looks like. I mean, we live in a digital age, and some of the medical students are a little bit like, when they have to give it. So I think in the future we might be looking at a different way of assessing that. The MoCA, the Montreal Cognitive Assessment, it doesn't have a clock drawing test, but it has some similar type of things. Yeah.
But if you ask someone to draw a digital clock, they're still going to have difficulty.
Yeah, they would have difficulty, drawing the digital
We
clock.
asked somebody to draw a clock, she drew a digital clock with the numbers on it. Like, okay, well, so we might have to go to that.
Yeah, so we might be changing it, yes.
So with the multiple administration of some of these screening tests, you just mentioned the practice effect, essentially. Is there any guidance in terms of how often you do the testing and what you do see in terms of repeated testing? Does it really decline? Blah, blah, blah.
Yeah, so repeated testing, and I don't know that there's great evidence on repeated testing. So typically, it's recommended that repeated testing is between 6 months and a year. So I like to repeat it yearly on people who are fairly stable. It ends up that because it's so incorporated into the way we room patients that they get it a lot more than I would necessarily expect them to, or would like them to, because then they do start to kind of recall it. But as the dementia starts to progress, even if they had memorized it before, they're no longer going to be able to do it, and you can track it. So a lot of these, you can track changes over time. There are many, many, many different kinds of tests, so you can also change it up. So we probably go back and forth with the SLUMS and the MoCA most often. Both are designed to pick up mild cognitive impairment, and then you kind of, if people, they're going to come in, they're getting ready to do their SLUMS, and then you switch it up and give them something else and see how they do. But they can be used to track changes over time, and that's usually what they do in the studies. So they'll check an MMSE at baseline and then again at 6 months or a year. Yeah.
Do you ever use the trail making? Do you use the trail making test?
So question is, so me personally, I don't do trail making tests, but I do value it. The trail making test is very good. I've seen it probably most commonly used during driver's evaluations, because it really helps with that perception and that how are they doing that planning for the next step? And if they are not able to do that, they are probably not able to go out on the road. So I think that's where I've seen it most often used, and I think it's very helpful, the trails making test.
Another technical question, has the pathology interpretation from, say, autopsy of the brain become more sophisticated? So, you know, if somebody had a diagnosis, say, 25 years ago of brain biopsy proven, quote, Alzheimer's disease, would they have been able to distinguish between that and hippocampal sclerosis or, you know, some of those other ones, or tauopathy? I mean, or was that really not in the, you know, it just has neurofibrillary tangles or something, and they said that's Alzheimer's disease?
Yeah, so how has the pathology, autopsy pathology progressed over time? And I am not the expert on that. We do have a brain bank at SLU, but it's with the geriatric psychiatry, and so they're kind of the ones that would be able to answer that better. But I would imagine yes. I mean, because a lot of these things we're just starting to find out. A lot of it comes from the pathology data to say, okay, we did all of these. So if you look at kind of they say that anywhere from 10 to 80% of people have the primary tauopathy, and so that's based on the autopsy samples. So it depends on who's the pathologist and what they're looking at and how they define it, and so it's probably somewhere in the middle there. But yeah, as our techniques get more sophisticated, as our understanding of these different conditions are more advanced, then the pathology in terms of autopsy is going to follow that as well. So, and that's why brain banks still exist, because we're continuing to learn from that. So a lot of this is from the brain bank information, and then that will then help us in the future to know what is the actual extent of these conditions. Excellent. Wonderful. Well, that gives us a little bit of time between speakers. That's good. Thank you, everybody.